is Diagnosis Glaucoma with your hosts, Dr. Mona Colleen
and Dr. Harry Quigley.
Hello, everyone, and welcome to episode 50 of Diagnosis Glaucoma. Today, we're going to be talking about caring for the whole patient, and we're going to be focusing on mental health services in ophthalmology. We're very pleased to have a special guest for you, Dr. Ethan Lester. Dr. Lester, can you please tell us your title, where you work, and just a little bit about yourself?
Yeah, hi. It's a great pleasure to be on your show today. So I'm a clinical psychologist by training. I work at Mass Eye in Boston, and I've been there for about 7 years now.
What was your transition to this role?
Well, it's kind of an interesting story. I don't think any psychologist in training is thinking, I'd really like to work with ophthalmology or ophthalmologic conditions. It was part of my fellowship. It was a rotation I had with a clinical supervisor, and we were doing work in the trauma service for our hospital. And I just wound up really enjoying the work and the patient population. And before I knew it, the resource of mental health at our hospital was becoming more and more obvious for our leadership. And that's how I got more involved with the other projects we have at our hospital.
Did this occur during your training to become a psychologist, or was this something that you started afterwards?
So for a psychologist in training, we have a 1-year internship, typically followed by a postdoctoral fellowship year or 2 years. The internship, it was the second half of my first year of training, where I got this clinical exposure. It was only 1 day a week in the ophthalmic trauma group. And
you are part of the Embedded Behavioral Health Service.
That's right. Yeah, that's actually a service that after 2020, a lot of mental health services changed. A lot of them went online. A lot of them were virtual, and so we were actually able at that time to expand beyond the ophthalmic trauma group that we were working with, and we were able to embed both in the vision rehab department at the hospital, as well as now we also work in the inherited retinal degeneration clinic for their patient population as well. So we service 3 ophthalmology departments. We service the ophthalmology department with these 3 clinical programs, and then we also have some clinical programs that stretch across the hospital to the otolaryngology side as well.
I think what you're doing is very important. We as physicians don't always address the emotional impact, the depression, the anxiety that is associated with a vision-associated disease or vision loss. I'm really happy to hear that this service is available for patients. And I think all of us are really interested in learning more about what you do, because again, it's something that is just not discussed enough, and it's very important to the work that we do in healthcare. Why is emotional well-being so important for patients with glaucoma and other chronic eye conditions from your standpoint?
Yeah, I think, looking just at the disease or diagnosis level, glaucoma is a lifelong illness, and it's chronic. When it's well maintained, it's somewhat predictable, but the actual outcomes of vision and functioning are always unpredictable. We're never sure exactly where the patient will land. And so patients often worry about their vision loss. Any patient who goes into clinic, I'm sure your ophthalmologist listeners will agree with this. There's a lot of anxiety in that exam room. And for the patients listening, that feeling of anxiety is warranted. It comes with a fear of the future, of a loss of independence. And what I've always thought and what I continue to believe for our patients is that being able to process this information and make those decisions about their care really gives them a sense of empowerment, even when the medical or ophthalmic condition is a bit more static. And those emotional support features actually help patients, in my opinion, feel more grounded in their experience of the illness and more engaged in their ophthalmology care as well.
I read reports of depression and anxiety being as high as 50% in patients with glaucoma, and I often have conversations with patients and their care providers, their spouse, their children, people who come with them, just about the emotional distress that they're experiencing at home. Just out of curiosity, do patients with glaucoma and other chronic eye conditions, what kind of access do they have to mental health services?
I think across the board, the access to mental health services is kind of this ironic problem, because on the one hand, it's never been easier to find a therapist, but at any level of specificity beyond a generalist, it's very hard to find somebody who's familiar with your specific medical issue. And then diving in even deeper to that, maybe an ophthalmic eye disease that causes some level of functional impairment. I mean, we have work groups right now that we're discussing what are some of the best practices for mental health providers working with patients who have vision loss. And, it comes down to simple things like accessing the forms, making sure that they complete things, the way clinics are laid out, how many steps into the building there might be, whether or not there's good access. So, I think to answer your question, on the one hand, there's a lot of resources out there, and I'd be happy to share, on what those resources are at a general level. But when it comes to your provider really understanding the experience of a person living with a visual illness and disability, that tends to be much more limited.
Do you hear patients comment on how they got referred to you? Like, are they generally referred by themselves or a family member, or is it a provider that actually tells them that they should go seek the services of a psychologist?
Yeah, it's an embedded model. So the neat thing about this kind of clinical service is that we're really part of these clinics. We're inside, often working side by side with the ophthalmologist or the optometrist, making these referrals. The way we control volume, because we service a very large area of New England, and the way that we best utilize this resource, one is getting those directed referrals from their ophthalmologist or optometrist, and they get channeled into our clinic workflow. I don't know the exact numbers, but it's probably 1 in 5 to 1 in 4 patients get channeled our way from each of these clinics. Not everybody needs mental health counseling or the need to speak with a psychologist about their challenges. But the other neat thing, in addition to having that volume and referral workflow, is the model of care we deliver is not one that needs to drag on for months or years. It's really what we call it is a brief skills-based psychology intervention or adjustment counseling intervention, where we're working with patients in the quickest amount of time possible for the shortest amount of time possible to produce the greatest impacts for them. In the treatment goals after the initial evaluation, once we've identified what the patient is wanting to work towards in terms of their mental and emotional adjustment to vision loss, we get after those goals right away. And I can elaborate more on that as well.
Dr. Lester, do you find that vision-related conditions impact emotional health as much as the physical health?
I think they hold hands in this challenging presentation, partly because it's hard to separate the two. The patient who's experiencing this physical health condition is maybe able to manage it, but the ways in which this impacts functioning or their distress, these are the variables that psychologists and mental health workers are really interested in. We often can't change the circumstance. I mean, if I had the magic wand or the magic drops or pills to make a person's glaucoma get better, I would love to be that person to do that. I can only imagine when that happens in ophthalmology practices where you have the answer, a medical answer for a problem or a surgical answer. But where we're coming in is really beyond what you could do to change that circumstance that seems pretty unchangeable. What sorts of resources, what sorts of coping strategies, techniques, can you facilitate for the patient, both in terms of their own learning, but their experience, to be able to say that, well, I don't have the best vision, but I don't really feel like this is the end of my life, or I don't feel like I'm not able to manage it, or look, I'm still able to do these things that I still really love and care about. And patients are very responsive to when the goals are both functional and secondarily symptom management, like reducing the depression and anxiety. But more importantly, patients are looking to just improve their quality of life and to better connect with the things they care about.
Do you think there's anything different about chronic eye disease that differs from other chronic conditions?
Chronic eye disease is one of these unbelievably metaphorical experiences. I mean, I worked in a clinic in my fellowship that was for patients with neurodegenerative disease, specifically ALS. And in those clinics, we're talking about end of life. And for some of our patients, the experience of losing vision is akin to an end of life process. the thought of losing their vision, the thought of losing their independence, their dignity, their functioning. And so I think the richness of the clinical work from a psychologist standpoint is that you're helping somebody really process and grieve in many ways the life that they hoped for themselves or that they wish they had. I'm not sure orthopedic injuries have that same kind of flavor. I'm not sure if medical illnesses that have some, even if there's chronicity, that there's some way of maintaining, you're not necessarily at the point of losing a primary sense, which for human beings, our primary sense is vision. And so, the whole world is set up this way for really valuing vision as our top sense. So when a patient loses that ability, it feels like they're losing a lot more than just their sight.
Yeah, and I sometimes wonder when I see patients over many years, I sort of wonder, what's like the chicken and the egg here? Is it the vision that is impacting them psychologically, emotionally, or is it like that they've already experiencing some emotional distress and that's making them negligent of their eye care and follow-ups and treatments and things like that? So it's kind of a hard question to answer. I don't know what people are doing or what they feel when they go home, but I often think about that in particular. I try to recommend vision rehabilitation services for patients, and I also keep a hand out in my office of vision therapists. But I am very curious to know if someone is seeking the services of a mental health specialist, how do they go about finding someone like yourself?
It's a great question. I think embedded models of care are still slow to uptake. I think there's been a lot of shifts, both in academic medicine, but non-academic medicine as well, of trying to get more voices in the patient's chart where they're talking less about some of the medical outcomes and more about their social, emotional, quality of life outcomes. I think the first place to start is probably asking your ophthalmologist if they have any resources that they typically connect people to. This might be a state-run agency, this might be a foundation or an organization, and even pulling on one thread tends to start untangling this messy ball of where do I get help. That being said, I think a general resource is still appropriate for patients with vision loss. I think websites like Psychology Today, which is an up-to-date directory where you can filter by zip code, by insurance, by preference of virtual or in-person. I mean, it's really a pretty sophisticated resource. I think what you want to find in a provider in mental health is someone who is both a good fit just interpersonally, they feel like the right fit for you, but also someone who's really able to and interested in learning about your challenges. And I think most people who get into the mental health profession do have that disposition, but it might require a little bit of education. I mean, I certainly didn't come into the ophthalmology work knowing everything there is to know about ophthalmic conditions. I had to learn, and my patients were great teachers for me. And so coming to the table with some resource sheets, maybe even an information sheet if you have a specific illness that you want your provider to know, I think mental health workers are often very open to learning and trying to be as helpful as possible.
Not everyone know what mental health services are or what that might look like for them in a session. Can you please just tell the listeners what exactly happens in one of these therapy sessions?
Yeah. We've come a long way in 110, 20 years. We're not, especially in our model of care, we're not having patients work with us for months or years on end on these nebulous problems or attachment-based problems. I mean, some of the stuff does come up, people's family of origin, if there's substance use. I mean, there's some really rich, deep clinical topics to get into. But for a service like ours, which is an embedded behavioral health service, we're first starting with the initial evaluation. And I kind of talk to my patients about this being similar to a physical exam when you go for a doctor's visit. It would be ridiculous to go to a doctor and them diagnose you with something without checking your vitals. And this is the same thing we're doing in that initial evaluation. We're asking questions about your medical history, about your social history, about your current challenges with all sorts of stuff. And at the end of that, we're able to conceptualize a working diagnosis, which in this clinic is most often the diagnosis of adjustment disorder. And that typically comes with some level of mood or distress challenges. And then we formulate a treatment plan that usually conforms to the 6 to 8 sessions over the course of about 3 months, where we're working together on goals that are identified both from that initial evaluation and on a every other week basis as we meet, further tightening up and identifying those goals that patients are really after, that they might not even know they want until they're making progress with a therapist.
And how do patients create those goals? Do you recommend journaling, that a person keep their own notes about their feelings on a day-to-day basis? How does that sort of work?
Yeah. People always ask me, what do I need to do to prepare for that first session? I say, you just need to show up and be ready to talk about yourself. And you'd be surprised how many people feel uncomfortable about doing that. But from there, a therapist or a psychologist may ask you to complete a couple worksheets. They might have you take a couple notes. Between intervals of sessions, they may ask you to start tracking things like thoughts, feelings, activities. This is all data. I mean, for example, one of my exercises I typically do with my patients in the first couple sessions is what we call an illness narrative worksheet, which we're trying to get patients who are adjusting to a visual illness to just construct the cohesive narrative that allows them to share in the future about how this illness is impacting them. It's really hard to explain to somebody what you're going through if you're not really sure of what you're going through first. So from that illness narrative worksheet, we'll then facilitate an illness disclosure worksheet. And, it's amazing how people can really craft that narrative and then be able to speak about it fluently just by completing some of these worksheets. But to answer your question simply, there's no real preparation prior to treatment, but depending on how engaged you are as a patient, you may want, to have a notebook and take notes during the week as well.
And how often do you recommend that a person go through these sessions?
Yeah, it's interesting. I mean, from our brief model of therapy, I think if we're working on something that is strictly adjustment related, so non-psychopathological, not something that's truly a mental illness, but rather a challenge with adjustment and a legitimate, appropriate reaction to vision loss, most of my patients are able to complete their time with me in 6 to 8 sessions, hour-long sessions over the course of about 3 months. So we're meeting every other week as opposed to every week. When you spread out that interval, it allows for more time for that patient to make contact with the resources you suggest. It allows patients to continue experimenting with different techniques that you give them. But I have had several patients over the years who come back for an additional booster or an additional piece of work. Sometimes it's when something in their vision changes. Sometimes it's unrelated to vision. Maybe it's, just a refresher on some of the skills that were discussed. But in terms of engagement, I would say when patients can plug in early and get their problems managed soon before they become chronic, then they typically don't need ongoing therapy much longer than the time that we offer it.
And how do you see mental health services actually supporting glaucoma treatment?
Yeah, I mean, this is something that we're looking, I think, for our 2026 goal is to try and expand into more of these subspecialties in our department at Mass Eye and Ear. I think glaucoma, as I said, is one of these illnesses that can present so diversely, and it's unclear, I think, the exact experience people with glaucoma have. But what I can, from my perspective, since I haven't worked in this clinical population outright, but from the patients I have treated with glaucoma, a lot of it is basically starting with problem solving. If patients are having, challenges with keeping up with their eye drop administration or making sure that they're getting their pressures checked regularly, I mean, this is all within the domain of behavioral health and behavioral medicine. I mean, that's our bread and butter. If people aren't taking their pills or if people aren't administering their drops correctly, we want to set up a schedule, we want to make plans, we want to set up contingencies and reinforcements. But beyond the practical, I think you do start venturing into some of this role transition, identity shifts. You start talking to people about their worries, their fears. On the other side of that coin, their values and what they want to keep doing. And we're helping people, I think, in other clinics, but I could see in glaucoma specifically, that piece of this of not needing to get focused on what does this look like at the end, but rather how are you living with it now, and having the confidence to be able to manage your life even if your vision continues to change.
I did want to point out data from some studies that have been published looking at patients with glaucoma who underwent a vision therapy curriculum that included mental health services. And what was observed was that patients who went through this program actually had an improvement in their overall mental health and also an improvement in just their general eye health. So the two are definitely related. How you feel about yourself, the quality of life that you have, it can impact your ability to comply with different therapies and just to maintain a healthier lifestyle and a healthier body. So the work that you do is very important, and I highly encourage any patient or any person, maybe a family member who's listening, to encourage those around you with glaucoma to seek mental health services and not to ignore this. And I also want to point out that some medications that we use to treat glaucoma have been associated with depression. So if you're feeling symptoms, something's just off, your mood is off, definitely talk to your provider. Maybe they can make a change to your medication.
Absolutely. I mean, I can't tell you how many patients, even outside of glaucoma, where the simple education on the eye drop you're taking can impact, steroids, for example, can impact the way you feel, emotionally. That can be a total game changer for patients. Just, knowledge is power, and being able to keep up with your providers and, ask for the resources you need it's so important.
So, Dr. Lester, if a patient is listening right now and they're struggling emotionally with their vision, what do you want them to know?
Yeah, I think it's what I would want any of my patients to know is that what you're feeling matters and it's understandable, and it doesn't mean that there's something wrong with you, and that emotional reactions to vision challenges are a normal response to such a big loss. It's not a personal failure. It's not a lack of your ability to manage your life. It's that you're really grappling with and reacting to something that anybody in your position would be feeling. And you don't have to manage it alone. This kind of support, whether it be mental health support, for some people it's spiritual or religious support, for some people it's family support, some people it's reading, who knows? When you can find the way that helps you cope best, it makes everything better. And sometimes we don't know what that is. So working with someone whose professional stance and specialties are to help people identify what their coping challenges might be and how to overcome them. I guess I would really want people to know that they're not alone and that there is hope for managing.
Yep, I couldn't agree with you more. And I know that the listeners would love to get a list of your recommendations for services, caregivers, or really anything that you could provide. If patients want to make appointments with you or support the work that you're doing, how can they do so?
Oh, I think be a squeaky wheel in your own ophthalmology department. I think, for one, unfortunately, a lot of our mental health services are constrained by, for one, just the volume. There aren't enough providers to number of people who need the support. The second is that mental health providers are bound by licensing restrictions. So you have to be licensed in the state in which you're seeing the person. And virtual care has made some options where people can be seen out of state, but best practice and always, seeing someone who really understands, the specific licensure requirements of your state. Yeah, and, being able to set up an appointment, like I said, I think for getting started, it's always great to have someone who knows this right off the bat. But what I would say is that if you can see the value of mental health of any kind and that treatment being helpful, I would start with general resources and go from there. Like I said, more people are willing to learn about this if you give them the chance, rather than needing to find just the right person at just the right time.
Well, thank you. This has been very informative. It's a very undiscussed topic. It's very critical to the care that we provide to our patients with vision impairment, and I see it in glaucoma. Thank you, Dr. Lester, for joining us.
Yes, thank you for having me. I appreciate the opportunity to talk about the patients that we've been caring for. And I agree with you. I think this topic is under discussed, but I even in the short time I've been working in the ophthalmology space, I feel like it's coming up year after year at our conferences, and our patients are asking for it. So it's encouraging to see mental health becoming more of a standard part of our patients' care at the hospital.
Great. Thank you so much again.
Thank you.
Thank you for joining us. Until next time, your mom says take your drops.